I'm Sam Hazledine, and today I'm here with Dr. Nina Sue. Nina is an advanced paediatric ED trainee. She is also the founder of the brilliant Revolving Door Syndrome podcast, and she's a very considered doctor who I would say is very mindful about her practice and about medicine and about healthcare. So it's really great to be here today to have a discussion with her about what we're calling the art of medicine. When we were preparing for this, we were talking about different names for this. Initially, it was going to be called Winning on the Wards, because we're kind of looking at the craft of medicine, but we decided that the art of medicine is really what it's all about, because this is that part of medicine that can really bring alive the academic and the science and make us really good doctors. So fantastic to have you here. Welcome, Nina.
Kia ora, thank you for having me.
So to some extent, as we discussed, our careers in healthcare, there's a lot of luck. There's complete luck or lack of luck with regard to who we work with as junior doctors. So, to some extent, there's luck involved in whether we get exposed to some great practices, some poor practices, what we can learn from, what we can learn not to do. So what we want to cover today is a distillation of some of the most important insights that we've seen, that you've seen, in what is our combined decades in medicine. So looking forward to getting into that. Now today we're going to cover a few areas. The first one is the importance of humility. This is going to be a really interesting discussion for junior doctors, particularly as you enter the wards. We're going to talk about time management, but from a bit of a left field perspective, I would say. We're going to talk about growing as a doctor, how to progress, how to become more of a doctor, and, unsurprisingly, we're going to talk about looking after yourself. So, Nina, anything you'd like to add?
Yeah, so to your point about humility and about luck of who we work with, I would say it goes even further back, in terms of humility. It's luck that we even got this far. It's luck that you ended up in a family and in a community that supported you so far to get you to university. And to a degree, it's luck of who you end up mingling with, who you end up working with to get into medical school as well. So I want people to remember, people who are, senior medical students or junior doctors, to remember that, it's a team sport, that you didn't get here all on your own, which is why it's so important that we give back as well in our practice, because, part of it is that we have a duty as doctors to help each other, and we don't always, how do I say this? I mean, what I guess I'm trying to get at is that I often see this attitude of medical students, my classmates, probably even myself a little bit, is that once you get into medical school, once you become a doctor, you can end up coming at it with a big sort of hot shot, I'm Mr. or Mrs. Big Doctor here, hot shot pants. And I think that kind of attitude can get in the way of your own personal growth as a medical student and a doctor.
Absolutely. And that's exactly why we're starting this discussion of the art of medicine with the importance of humility. We are fortunate to be in this position of being doctors. For every person who gets in and is a doctor, there are tens of people who would love to take that spot. So, I think starting this conversation around humility is really important. And you began that with, essentially, and I agree, to get into medical school, you have to be great academically. And then you probably, these, people in medical school, let's think back to it, or you might be there at the moment. Most people are pretty good at other stuff too. These are high performing people. And, when it comes to humility, there's a reality that when you start work on the wards, you're probably not the most useful member of the team, wouldn't you say, Nina?
I think that realization has come through experience over time, right? I think when you're in it as a medical student or a more junior doctor, it's hard to realize these things, and you realize them as you go on. So I don't know if it's an attitude change or anything, but it's easy to understand how doctors when we were medical students might have been a bit more annoyed when I was a medical student, because the thing is that when you're a junior doctor or a medical student, you often you need to learn more than the skills that you can bring to the team, if that makes sense. And there is like a need, I guess, when you're a medical student to sort of pay your dues in a way. As a medical student or a junior doctor, even now, I would never be offended if, say, one of my senior members asked me, "Hey, do you reckon you can go like get coffees for the team?" And I'd be like, "Oh yeah, absolutely. I will go for a walk. And do you want a flat white? Do you want a hot chocolate? Yeah, I'll be a man. And so I think there's some growing ideas that medical students shouldn't be doing this or shouldn't be doing that. That they're here to learn and be part of the team. And that's true. Medical students are definitely here to learn to how to be a doctor, but it's a team, like I say, it's a team sport. And I guess the humility part is recognizing that, when you're coming into this space, that the doctors have different running priorities. One of the priorities is looking after the patients. One of the priorities is looking after their colleagues and and themselves. And the other priority is, of course, training the next generation. And what I've been noticing, at least in the last couple of years, especially around pandemic times, is that you can only pick two, right? In terms of your priorities, you can either look after the patient, look after yourself and your colleagues, or look after the students, especially when things are getting tough, right? So I feel like part of it is that we've let some medical education go to the wayside, and so our medical education for our students is, we don't have as much time for that. So I guess what I'm saying with the humility wise is that there's just not a lot of space for doctors to, I guess, do that good education that we used to have, and that if you, as a medical student or junior doctor, you really want those education opportunities, I think it's hard to say this, but it's becoming a more transactional kind of relationship, where if you want to get that value of a quality medical education, I think in these times you kind of have to bring some value to the table as well. You've got to be like, hey, I'm a member of the team. I will go do that thing for you. It might be a menial task, but I'm going to do that because I know it's going to free up some time from the doctors to actually teach me something valuable. And if you show that value that, hey, I want to help out, and show that I'm actually really keen, people will, want to help you and support you and bring you up. And in doing that, as well as, I think it teaches you humility in the sense that there aren't jobs that are like, this is the doctor's job or this is the nurse's job. All the way since I was a medical student, I would always do things that are considered not necessarily the doctor's job, and I think your colleagues appreciate that. And I'm talking about, and I work in the children's emergency department. So a lot of the tasks that are considered nurses' jobs, or that some people might think that they're above, and I'm talking about my colleagues as doctors, some people wouldn't, when a patient is being discharged, for example, and they've got an IV drip in, if it takes me longer to go and find someone to do something than it would take for me to do myself, I'll just do it. If a patient's going to go home and all they need is their IV drip out, I'll just take it out and give them a plaster and away they go. There's no point in wasting the patient's time, the nurse's time, and my time if all that's required is me to do this job that is not a doctor's job. So that's what I guess I'm trying to say about humility, is that if you can just get the job done, regardless of where you are in this hierarchy, your team will appreciate it, your patients will appreciate it, and the energy that you put out is the energy that will come back to you. Does that make sense?
Makes total sense. And as you were talking, it made me think about what is learning and what is that path of growing as a doctor. And if we come at it from the perspective of learning is pure knowledge, then yes, you could get quite, I should be being taught by my senior colleagues specifically. But if we come at it from an art of medicine perspective, that being a doctor, one part is your academic knowledge, one huge part is how you work as a team member and how you can lead and galvanize people to create, to drive incredible patient care, then that learning can be happening all the time. I'm quite interested in Zen Buddhism, and you read, stories about people who become, enlightened sort of Zen Buddhist leaders. They all start at the bottom. They all start sweeping floors for 14 hours a day, and they may do that for years. And I think part of us as becoming good doctors is actually looking at that and not seeing it as this is the menial work that the most important person on the team is doing, but just seeing that as being an important cog in a well-functioning team. And I think it's just a different perspective, a different way to come at it, rather, which allows you to be a really useful team member. I was thinking back to when I was a medical student. I think I was my fourth year medical student, and I was working with a doctor, Dr. Erica Winneray Kelly. I still remember her because I was just doing everything to help. Everything I could, and because I was being useful, she's like, "Do you want to come on the long day with me?" And and she let me assist in surgeries. And as a fourth year medical student, this was just the dream come true for me. But it made me realize that it made me think that if you fill the bank before you sort of take withdrawals from the bank, then your senior colleagues are going to be infinitely more likely to actually want to teach and get you involved and go that extra mile, because they're going to feel good about you rather than what they can feel about you, which is you're an interruption and you're actually slowing down the process.
I mean, I hate to say it, but that's the truth, right? That's the truth, because the reality is that the doctors are not actually paid to teach medical students. We all kind of do it because we want to, or we know that we have to, because if we don't do it, we know that those medical students are going to come through without the skills, without the training required to actually do the job when it comes to their time. So I think just to recognize that we're all human, and we all have our human wants and needs of how we approach these tasks. And the other part of humility is the working with nurses that I mentioned before. I would say that time and time again, one of the best things that I have done in my medical training and my career is to always make sure that the nurses are happy. Because if the nurses are happy, like it's I don't want to say it's like happy wife, happy life, but in the sense that if you make sure that they're happy, if you make sure, I mean, I have male nurse colleagues as well, but you know what I mean. If you keep them happy, if you keep that relationship good, and it's not just the working together in the purely professional way, it's just the asking people about themselves. It's the things they don't teach you in medical school, which is that collegial relationships matter. Just asking them, hey, what did you guys get up to in the weekend? And then remembering stuff about people, being like, oh yeah, I heard you had a squash tournament the other day. How did that go? It's these like little things that people don't realize make a huge difference, because once you have that mutual respect from the nursing staff or your other colleagues, things just happen for you. Like people start wanting to do stuff for you because they respect you, and they just like working with you. So I think this is something that's missing in our medical education.
No, I 100% agree. And there's a trap that we can fall into as doctors and junior doctors is the trap of medicine is hierarchical, but the trap is acting like it's hierarchical. And coming at it from, I'm a doctor, I'm above your whatever role someone else is. And I completely agree. It's the worst approach you can have. The best thing you can do as a junior doctor is make allies with the nursing staff. Make friends with the charge nurse, who often comes across as a bit of a battle axe, but actually when you get under the skin, they're quite lovable. And you got to find that lovable part. But if you make friends with the charge nurse, just do just do silly, obvious things, like bring muffins on a Monday morning, like if you actually make friends with them. But then the second part is actually respecting them and their opinion too. And to be honest, you should respect them and their opinion. When as a junior doctor, you start to realize how ill-prepared you are for being a junior doctor from medical school. And the best thing I would ever find if I'm in with a patient and I really was, look at the nurse and just say, what would you do in this situation? Like you're involving them, but the reality is you're not involving them. You really are asking them, and they'll say something, and you'd be like, that's exactly what I'd do too. And it was funny how often I would agree with the nurse when I had no idea what I was doing. And so I think, really actually realizing that they have a lot more practical experience in terms of how to look after patients, and really tapping into that. The other part that we had discussed as a junior doctor is also realizing the parts that are yours and yours alone. Like knowing what, there's parts where you're part of a team and you're kind of just, people are carrying you and helping you and teaching you, but there's also parts that you can really own, aren't there?
Definitely. There's definitely, obviously we need junior doctors, we need medical students, we need trainee interns. And I guess what I would like people to realize is that the job that you are given, just do that job really, really well. If your job is to take notes for every patient in the ward round and jot down all of the jobs that you need to do for each patient, just do that job really, really well. I think sometimes people want to get a bit ahead of themselves and, sort of want to come up with all these weird and wonderful, differential diagnoses. And that can complicate things a little bit further. For example, if you say something in front of a patient and then they'll start Googling something, or, then you're adding to the cognitive load of the other junior doctors who have to figure out why it's not all of these differential diagnoses. And it can be helpful if you're asking, isn't it, inquisitively, like, what do you think about so-and-so syndrome or blah, blah, blah? Like, would that be a relevant sort of thing, sort of a later date when there's a bit more time later on? But, on reflection of my own training, I'm like, yeah, I came into the world I came into being a house officer pretty well prepared compared to some of my colleagues, but at the same time, not well prepared. I don't think anybody comes into being a house officer well prepared. You're a doctor, but I feel like your doctoring doesn't really begin straight away, at least for a few months.
Absolutely. And I think that sort of Zen mind, beginner's mind, I remember reading a study about death rates in hospitals that go up when the new intake come in. Like if we go in there thinking we're better than we are, then we make mistakes. If we go in with that beginner's mind and you're there to learn, and I'll do the jobs that I'm given really, really well, as you say, take the notes. I'm not going to take the notes and try and look like a smart ass and ask silly questions in front of a patient which freaks them out. Like, that doesn't benefit anyone. I'm going to just really do my job. Referrals is another thing that as a junior doctor you can do really, really well. Make sure you've done everything first so that you build relationships with the med-reg, who you're going to need, that when they get a call from you, they know that you've actually done everything properly. They're not going to have to go, have you done this, and you go, no, and they go, well, can you do this? Because then you start to get a combative relationship in referrals, which is they try and push you off, as opposed to, oh, I got a call from someone I need. Like, we can really take that approach of mastering what seems like menial things, but all those menial things put together round out the great doctor, don't they?
And I tell you, I feel like you can notice the doctors who really spent the time in training in medical school, really honing that craft before they graduated. I think a lot of people take their time in medical school for granted. A lot of people, I remember when I was in medical school, people would brag about, I got sent home early like this day. Ha ha ha. It was like a really, really good time because I only had to stay like 2 half days this week, basically. And I just think on reflection, I'm like, man, like those people really missed opportunities. When you're in medical school, this is your opportunity to try and learn as much as you can, where you have no responsibility. That's the best time that you can learn.
And then as a junior doctor, once you've got that responsibility, it's like really hone the basics. But, build a foundation. Think about it that way. Humility is building a foundation, and the foundation is the basics that make up this whole picture that is patient care.
And back to your point about doing referrals, I think it's what I appreciate most as somebody who both has had to accept referrals and also do referrals is having a clear idea that the person that's calling has actually put in time and effort and really thought about it and try to anticipate, what they might need and have a really clear question for the other person on the other side of the phone. Because when you're a person receiving that phone call, you don't have the patient in front of you. It's really hard to know what's going on unless you have somebody who's able to really describe succinctly and make you really be able to picture that person in your head. And when you can do that, then it makes the other person's job so much easier to actually give you specific advice or, say, yeah, okay, no, that's a very good referral. Please send them in, etc., etc.
So I think that's that first part. If we approach healthcare, if we approach our careers, medicine, with this attitude of humility, as a junior doctor, as a medical student, building, from that place of a beginner's mind, then we set ourselves up really well. Now, the second area that we wanted to talk about is just some real basics about how to best manage time, because that is such an important part of a job that is always bigger than the time allotted, to an extent. So let's talk about that.
So I think it's tricky because it depends on the job that you're in, right? It would depend whether you're working in the emergency department or in the wards or in a clinic. And no method is perfect for everybody and every department, every location. For most of junior doctors, especially in the first couple of years, probably the setting would be in a ward, doing ward rounds. And it can be really challenging, especially in these times when we're feeling quite understaffed and overworked. And when we're in those situations, increasing cognitive load is a huge issue. I can be very forgetful easily when the huge amount of demands and you're task switching all the time. And studies show that having to task switch all the time really reduces your cognitive abilities. And this is like a pretty simple thing that I do, which I think a lot of people do, is just writing it down, having a patient list. Most teams will have a patient list of all the patients that they see on their ward round, but just documenting sort of which patients have blood tests that need to be done, or scans needed to be ordered, or people that need to be referred, and so on and so on. And just writing that down on your patient list is super helpful. And I like to do a thing where I sort of draw like a square next to the thing that needs to be done, and then so an empty square means it's yet to be done. A half shaded in square means that one of the things has been actioned. For example, a blood test has been ordered or the blood test is done. And then if it's fully shaded, then it means the blood test is back and I don't need to chase it anymore. So that's what I do. But I guess the problem is that you've got to guard that piece of paper with your life. Because I have gotten into trouble when I've lost it and I'm like, oh no, what are the jobs? And then you have to go one by one through all the notes and collect all those jobs again. So guard that piece of paper with your life, write your phone number on it if you have to, and also make sure, I guess, your notes. What's that?
Put a reward sticker on it. You find this, you get $100. Yeah.
Make sure people can actually read your writing, but also, I guess, make sure your documentation on the ward round is good as well. Because, do you know, it's not until you've actually gone through some sort of investigation for patient harm in some way or other, then you realize that actually documentation is so important. And especially when I was working in the emergency department, it was super busy. I was like, I have to take even more notice of what I'm writing down, because if you don't document it, then you're in the doo-doo basically if something goes wrong. And that happened to me, and I'm glad that I really spent that time to document, because when patient harm happens and you know that you did all the right things, it's the documentation is like more evidence to show there was actually someone else and not you or the system, right?
You've got to have a fail-safe system, because you can't in such a broad, varied environment. If you rely on your memory, you're gonna forget at different times. So the system has to protect you. Dr. Michelle Downey, I still remember when she first taught me, put a bracket around the jobs that need to be done, and then once you've done it, you put a line through it. Like I still do that with everything, because it's the system. If there's an open bracket, you know it hasn't been done. And so I think that's the first point is develop a system, write it down, but also develop a system that is a fail safe, because we shouldn't rely on our own memories. And then the second point we talked about, which I thought was really good about how you do this, is about the importance of being preemptive and the value a junior doctor can bring by being preemptive.
It shows that you're really thinking about it, and that's how you practice being a doctor. A lot of being a doctor is just thinking and reflecting on, if part of it is pattern recognition, right? You're like, oh, well, patient has X, Y, and Z, so it could be ABC, and so I need to order these tests or think about ordering these tests because based on previous experience it's this. So that's really good to have some pattern recognition, but also thinking outside the box a little bit as well. Does this all make sense? Does this patient actually fit into this box really neatly, or is there something a little bit off about this patient, and do I need to be thinking a little bit more broadly? Because you're not always going to be right.
Yeah, absolutely. And I thought a really interesting point you made, which is coming back to the point about doing your job, doing the thing that you can do, the value you can bring really, really well. As a junior doctor, you talked about, discharging patients first and early, because that is a role. You can increase the bed capacity of your hospital if you don't leave discharges to your timetable, but prioritize them so that you clear the bed out ready for someone else.
I think it depends on how the team is run and what level of seniority you are, right? So some departments do a non-split round. We have everyone on the team going from patient to patient to patient, and what can work for that kind of team is a house officer or two house officers who switch over, and one just does the discharge while the rest of the team move on to the next patient. That works really well, and just making sure that you have a good discharge summary that is succinct and has the very clear discharge plan for both the patient and the GP that you're essentially discharging the patient to. When you're a little bit more senior and you have the ability to make decisions yourself, and you work in a department where you have split rounds, for example, I think it's important that you do select patients who you think are ready to go home based on your handover from the night shift, because that really helps with bed flow, right? Because if you, for example, I've had patients who've got viral-induced wheeze or bronchiolitis in my paediatric patients, and if you know that they are well enough in the morning after treatment overnight, then you can just send them home, see them on a ward round, send them home. And then that really helps, because then you don't have to see them again later. You don't have to re-review them if you don't think so. And it helps with bed flow. So if you can get that patient out, that means that ED can get another patient in.
Being preemptive, getting ahead of things, is an area that junior doctors can have a huge impact on. So let's talk about the next area as well, about growing as a doctor, because we call it the practice of medicine, where we're always growing. This is what we signed up for. Let's talk about how you would approach or how you have approached that growth as a doctor in improving your practice of the art of medicine.
I think one of the most important things that you can do as a junior doctor and a medical student is just showing initiative, right? I think one of my senior colleagues, a professor, he really noticed me when I was just a first year pediatric registrar, and one of the things he noticed was like, oh, Nina, you really take control of your patients, like you really take ownership, and that's not something that we see necessarily so much at your level, right? Like a lot of people are sort of like waiting around for somebody more senior perhaps to give them advice. And, that's not to say all people should make all decisions for their patients. What I'm saying is like take ownership to be like, hey, what is the best thing that I can do for my patient? And really advocate for them and really make sure they have all the things done. and have all the services required for them, because I'm like, this is on me. I'm their doctor. Does that kind of make sense?
Yeah, it's almost like our conversation about humility doesn't mean that you're passive.
You're still an advocate for your patient, yeah, and making sure that they have all the things that they need, and really being like, oh, you got to, these are all their problems, I guess you call them your problem list, and I want to make sure that there's a plan for every single one of them. I'm not necessarily the one that's deciding on the plan, but I'm going to make sure that they're all sorted out, that all the boxes are crossed out.
Yeah, absolutely. I think that initiative is just such an important factor about being a great doctor. And beyond that, you've got some great practices that you've used with regards to self-reflection so that you grow, haven't you?
Yeah, so one of the things they do, and this is probably more specific to working in an emergency department, is that every time at the beginning of a shift, I try and go back and look at my patients from a previous shift. Sometimes I have to go back even further, because nothing might have happened for your patients from the day before, but if you're looking at your patients from a week before, you might actually see some results, right? You might say, oh, did that patient that I discharged home, did they bounce back? Was it a safe discharge, or was it a not safe discharge? Did they bounce back really sick and I missed something? That patient that I admitted to orthopedics, did they have, osteoarthritis, septic arthritis or not? I think these are really important, because especially in emergency or in acute medicine in general, you don't follow up your patients properly. If you don't go back and actually look at their results, you won't know. It's not like in general practice where you're supposed to have continuity of care, where you see your patient and then you ask them to come back in a month's time to see how things are going. You don't get to do that in acute medicine. So this is my one way of being like, hey, I'm actually going to see if what I said was actually the right thing or not.
Yeah, but as a junior doctor, you can do the same thing when you refer on to the med reg or refer on, like, just following up. I mean, when you talked to me about this, I thought back to my time as a junior doctor, and I did not do this very well at all.
Nobody tells you that you should do it.
No, but I just sort of thought of, you were doing your orthopedic run, and you flick them off to the med reg, and they're off my job list now. But what I missed out on was a huge opportunity to actually learn from every patient and to become a better doctor. It's almost like you've done 90% of the job or 95% of the job. If you just do the final 5%, you're going to get 5 times as much learning. And it just seems like it's such an obvious thing to do when you say it out loud.
And it only takes me like 15 or 20 minutes to do it max. And I definitely think I gain something from it every day.
Yeah. And the point, though, I think when I was listening to you was, we've talked about time management, and there's always more to fill than there probably is the time to do it. And so this could be a job that we just go, isn't important enough to get on my to-do list. It's at the very bottom every day. But if we do that, we probably it's the why. We dramatically reduce our growth, our learning as a doctor. We talked about earlier about, seeking teaching from our senior colleagues. Well, this is a way of getting teaching that is far more practical and far more relevant to us, as in terms of our growth and journey, isn't it?
Yeah, it's one of the many things we could be doing. I mean, the other thing that I think about as well is feedback, right? So one of the jobs that I think really helped me really early on and really accelerated my development was working in children's emergency department as a second year house officer. That job was what really catapulted me into what I'm doing now, which is paediatric emergency advanced training. So that job at that time was just, there was a lot of opportunity for growth, because you would see a patient, you'd present to a consultant, and they would give you feedback immediately. And that sort of immediate feedback allowed me to reflect on what that feedback was and just do it better next time. And every time I was able to do it better every time, and that growth was huge. And I'm saying that it may not be the same today, and it may not be the same in the department that you're working at, but the value is still there in just asking for feedback, saying, hey, that referral that I did, do you reckon I did a good job? Or when I took that patient's medication histories, is something I could have done a bit better? The discharge summary that I did, is there some more information that you think I should put in. You know, taking a little bit of time to get some feedback and getting it more, like small amounts of feedback more often is far more useful than just waiting until your mid-run, end-of-run feedback, because by then it's a little bit too late.
And people have forgotten, or there's nothing you can do about it in that just in time. I think it comes back to that humility point, doesn't it? It's like, you know, I may think I'm good, but I know I can be better. It's probably, you know,
there's always room for growth.
There's always room for growth.
I've got plenty of room for growth, put it that way.
It's funny though, I would say now I see more room for growth in myself than I saw when I was a late 20s junior doctor.
It's the Dunning-Kruger effect, right? It's the thing that you think you're a hot shot, you're at the peak of stupidity.
The peak of stupidity.
Yeah, I think it's what it's called. And then you're like, I can't remember what the down slope is. And then I feel like I'm sliding to be in that that upward slope of sustainability. I think that's what it's called.
But it's great, as you say. You've got those opportunities. You see them at Reg at lunch. You know, what could I have done better in that one? Or, you know, it's just that, you know, beginner's mind is I'm seeking to grow. And if we approach this is the kind of the mindset of I'm here to grow, then of course I'm looking for where I could have been better. I'm not just looking for the pats on the back.
And I would say that, you know, asking for feedback is not something that comes naturally to me as well. It's something that I've had to work on. I think, you know, my whole generation, millennials, and probably Gen Z probably have this as well, is that, you know, that discomfort. It's really difficult to deal with that level of discomfort. But it's actually really only through discomfort that we grow. So
we want to lean into it, which leads us into the next point we discussed. Because we're seeking feedback, we're looking for ways to grow, and we talked about, you know, balancing this balance that we have as junior doctors of questioning ourselves, looking for areas of opportunity to grow, and confidence, looking for areas that we can lean into. So how do you approach that? You know, which is a daily balance for junior doctors.
Hard because it's obviously different depending on where you're at and what your sort of level of experience is. But no matter where you are, if you are not reflective and asking for that feedback, you will not know where you are in terms of how your progress is going. And I suspect that that's probably an issue for lots of people. There's a mismatch between their level of confidence and their level of skills and experience and decision making.
So there's a mindfulness to know you've actually got to know where you are.
Yes, exactly. So I think personally I've probably run into trouble where I have probably just agreed with whatever the other person said on the end of the phone, because I probably swing towards being a bit of a people pleaser myself, and that's probably one of my flaws, is that I don't want to trouble people, you know. I don't want to create more work for other people, and so I think that's one of my flaws, is I kind of just let things slide. And I think when I let things slide, I on reflection I'm like, oh, actually that probably ended up in patient harm because they didn't get the investigation they needed in time, or the treatment they needed in time, and they got it, but you know, they could have gotten it sooner, if that makes sense. So that's that recognition that actually maybe I have more skills and experience in my confidence level, and some other people may have more confidence in their experience and knowledge skills, and sort of be cognizant that there are both types of people around, if that makes sense.
And probably understanding where you are. I was the other type of doctor. I overestimated my abilities considerably so. And, you know, working in emergency, you've got a lot of opportunity to throw yourself into new situations if that's what you like. And I think back to, you know, the times where I potentially could have or did, you know, cause patient harm. It was often where I was like, you know, Sam, can you take this? Absolutely. My answer was always yes, because I backed myself. But actually what you've got to do in those to be a good doctor, you've actually got to think about it and be able to go, well, no, I'm not the best person in the situation. Like, I'm not going to take a difficult intubation when I've never intubated someone, for example, as opposed to, yeah, I'll give it a go because that's, you know, the type of person I am. And so I think that that's a huge thing, is to really think about and be mindful enough to go, take a moment, take a pause and think about the safety, think about the consequences, and think about whether you are the best person or whether you want to do this for you, because it would be, if you nail it, then you're great. But actually, maybe there's a safer way for you to learn that skill.
Yeah, I agree. But I think saying yes to stuff is still a really good idea, because if somebody's asking you to do something, they are trusting that you're going to give it a good go, and that if you needed help, you will ask for help as well. So I think that's what you're going to do. Say yes, but also ask for help and know that you may need help.
The assumption there, though, is that the person is also being mindful. Like, there is a danger in that, because if they are a stressed, busy head of department and that you've been working with them for less than a week, they may just think, well, I'm going to assume Sam can do that because it's easier for me to assume he can than think he can't.
I get what you mean. I think what I noticed, what some of my ED consultant colleagues do is that when we've got a patient who's really sick and we need intensive care to come down, they'll often ask the intensive care doctor, what's your background? Because our intensive care colleagues, the registrars, they could be intensive care doctors, they could be anaesthetic doctors, they could be emergency doctors, and they could also be very different levels of experience in those three different domains. You could have a patient who needs to be intubated, and your intensive care doctor that comes round as a anaesthetist who's done thousands of intubations. You're like, yeah, we're sweet. But it could also be a first year ICU registrar who's done about 3 intubations as well. So sort of that recognition that sometimes if you're that ICU registrar coming down, asking you is not about whether you're good enough or whatever. It's about understanding safety for the patient, because in certain cases you want to make sure that, like you say, for the difficult intubation, you want to make sure it's the best intubator in the room or in the hospital that's able to do it.
Yeah, absolutely. And, again, it's this humility piece, but also this seeking to just do the best that we can for our patients and being okay with us not being the best solution every single time. Thinking about them, but also being, giving ourselves enough leeway, as you say, to say yes and go, well, I haven't done this before, but, this is not a difficult intubation and I'm happy to do it, but could you just be there just in case? So it's good. And I think there's one other area that we discuss, which I think is so important about our growth as doctors, and it's about our practice as doctors. It's almost a section in and of itself, but it's about how important our words are when we're doctors, isn't it? We talked about this, and just, you can't underestimate the importance that, the words that come out of our mouths, they matter, don't they?
100%. And it matters whether it's for our colleagues or for our patients. There was this movement at the NHS, I think it was called Civility Saves Lives. So, I've experienced it myself, where it just takes one person, it could be a patient, could be another colleague, to have a go at you. And that's your day ruined. It could be your week ruined if someone just takes their frustrations and anger out on you, and it makes you feel like you did a bad job, that you're a bad doctor, and that it probably makes you more likely to make mistakes because you're so affected by this one comment that somebody's made. And I do see this in a lot of my colleagues who are probably burned out but don't know that they are, and they make throwaway comments about people around them, whether it's to their face or behind their backs. And then they make comments like, or they're just very difficult to talk to on the phone, to ask for help, very, what's the word? Very like demeaning, that kind of thing. And that kind of attitude and way of talking to people can really stuff up someone else's day. And then that cycle repeats, and that person might stuff up someone else's day until this never-ending cycle. And that's how I think toxic departments get created. So that's one part of it, where what we talk about and how we talk to people really matters. And I would say the other part is how we talk to patients, really. As doctors, we are in an incredibly privileged position. I have to reflect on this myself a lot and keep reminding myself. When I show up to a shift in the emergency department and I'm seeing my 10th, 11th, 12th, 13th patient, they may be the 12th, 13th, 14th patient I've seen of the day, but I'm probably the first doctor that they've seen that day. I could be the first doctor that they've met in the last couple of years. So how I behave with them and how I talk to them and what I say to them can have profound effects on how they see themselves, how they see healthcare, and how they move forward with what they do about their health. I think people don't realize that, and then just like, oh yeah, blah, 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 about the patient, not realizing that as doctors, people really actually do want to listen to what we say. And, you know, there's going to be naysayers out there to be like, oh, doctors don't listen, doctors don't know what they're talking about, blah, blah, blah. But by and large, patients really do respect what we have to say. And if we tell them stuff like, you know, I'm really worried about your health, and you seem really stressed, and I think that there are some really important lifestyle things that we can do, to prioritize you, just simple things like, reducing your screen time before bed, just prioritizing sleep, prioritizing eating more whole foods, and more activity. And that can start by just taking the bus instead of driving. That can start by taking the stairs instead of taking the elevator. I've had moments where patients just have this sort of like light bulb click moment in their head, and they're like, oh, it's as easy as that. Alternatively, I can just say, oh yeah, all your symptoms are just due to stress. Okay, bye. And the experience of the patient is totally different. And all I do is take an extra 5 minutes to really explain to people about how to take charge of their own health and what they can do to make sure they don't have to come back and see me in the emergency department again. So our words matter so much to our patients and our colleagues.
Yeah, I 100% agree. And I think there's a danger sometimes I think that doctors fall into, or not just doctors, healthcare professionals fall into, which is, this idea of not wanting to give false hope. And so they overcorrect. And the way that we talk, I've done a lot of work in terms of my own personal development and psychology, and understanding the importance of how we talk to ourselves. And the words that we use, but the words that we use with others, particularly as doctors, really, really matter. And there's ways to deliver, and I think this is something a good doctor masters, the ability to deliver all kinds of news in a way that the patient can still leave feeling empowered. For example, say someone's got a cancer that's got a 20% survival rate. There's two different ways to present that. One is, look, you're super unlikely to survive this. 80% of people die, and so start handling your affairs. And I've heard of doctors who speak like that. The other way is, look, 80% of people die from this. 20% of people don't. We're going to do what we can to put you in that 20%. You can do what you can to put yourself in that 20% with your diet, with your exercise, with sleep. There's other things, to be able to present it in a different way, to go actually, and I remember my mother-in-law, well, she's dead now, and the doctor said to her something, it's like, this is just a challenge, but your heart is as strong as an ox. And she kept quoting that. She really latched onto that, and that was good for her. It was good for her to believe her heart was as strong as an ox, because it gave her okay, well, I can throw myself into this. And I think it's just so important how we position things. I had a recent example with my daughter who had a tonsillectomy, and she gets really worried about sleep. She's had, some challenges with sleep, and we've done a whole lot of stuff, and she's getting pretty good. She's getting there now. She goes in the hospital. Her main worry was not the tonsillectomy, it was, will I be able to sleep in the hospital? And this bloody nurse came in at 10 p.m. We'd just got things going, and I'd said to her, can we get a melatonin? She's like, no, you can't do melatonin because whatever it is. And but then she looks at Flossie and she's like, look, you're going to have a really bad sleep. This is going to be a horrible night. You're going to have a terrible sleep. And I was like, whoa, pulled her aside. And I'm like, I was just like, you don't talk to my daughter like that. She's worried about sleep. Don't sow the seeds of this is a definite, you're going to have an awful night. And she's like, well, I just want to give them the worst possible case scenario because just in case it turns out like that. And I was like, well, that's one thing. But there's different ways to communicate that same thing as, we're going to have to wake you up every couple of hours.
It's a self-fulfilling prophecy now.
So, best thing you can do is try and stay calm and you go back to sleep and, you may have a bad night's sleep, but you actually might be fine. There's just different ways to communicate the same information. And I think as doctors, it's upon us because, as you say, people actually do listen to what we say, and people don't only listen, they latch onto the specific words that we use, don't they?
I think to your point before about the cancer story, I think it's important both to have the optimism, but also the realism as well. Whether it's cancer, whether it's anything else. Like when I discharge my patients, this is back to the setting of paediatric emergency, and we get so many kids coming through with a cough, cold, runny nose, fever, that kind of thing. I always, and I'm pretty certain that the child is well enough to go home and they probably won't come back. But I think it's important, again, back to the humility thing of realizing that we could be wrong. And I say this to my patients. I say, hey, look, I think your child's just got a viral illness. They look really well. I'm happy for you guys to go home. I think she'll be safe as long as you feel comfortable to come back, and as long as you feel like in the middle of the night, 2 a.m, if you're worried, that you can make it back easy. Yeah. I want you to do this, this, and this. And if this happens or that happens, I want you to come back. Because although I think she's well right now, she may get worse. This could be the beginning of, a more serious illness, and I could be wrong. And so if I'm wrong, I would like you to bring your child back. And so that's recognized, and that's giving that patient the idea like, oh yeah, this doctor, she's pretty certain, but she also recognizes that things can change. And so if she's wrong and and she's saying that she could be wrong, I still feel like I could bring my patient back, because the trap that you don't want to fall in is saying your child is absolutely fine, blah blah blah, because then, like you say, patients might latch on to that and say, oh, but the doctor said my kid was fine, so I'm not going to bring them back. They're just... Despite
the fact they're completely decompensating in front of them. Absolutely. Yep. So the art is being mindful of the words we use, isn't it? The art is delivering reality, delivering the possibility of things turning, going well, but also while keeping the door of, here's what happens if they don't. It's the key though is being really conscious of how we deliver those messages, isn't it?
Well, it's recognizing that as doctors, we're human beings and patients are also human beings. I think a lot of us have lost that or forgotten it, or we're never taught that. We're so messed up in this doctor-patient relationship. And, there are problems when it becomes too close, like when there's complete loss of respect for one another, that, oh, doctors don't know anything. It's like, oh, no, doctors know something, but we also don't know everything.
Absolutely. So I think, it's just such an important skill. So I think that covers some of the core areas, I think, as growth as a doctor. And then we're moving on to the final area we wanted to discuss today, which probably doesn't need a huge amount of time today because we've covered it in great detail in other areas. But it's the art of medicine means also looking after yourself, doesn't it? What does that mean for you, Nina?
See, I'm somebody who's bounced in and out of burnout a lot through medical school and through practice. And I still haven't 100% figured out. I don't know if anyone can really figure it out, because, we don't even call it burnout anymore. We call it moral injury, because a lot of it is like systemic. It's a lot of it is circumstantial. But all we can do is do the best that we can for ourselves. And for me, what I try to do is I prioritize sleep. That is like number one. And, my partner and I, we've done things like we've made the rule that the bedroom, there are no screens in the bedroom, because before we did that, we would just be on our phone scrolling for like an hour before we eventually go to bed and have a terrible sleep, wake up to the alarm clock that's on our phones, and then scroll a bit before we get out of bed. And now that has completely changed our life, made our relationship so much better. we make a huge amount of effort to eat well because, there is that saying, apple a day keeps a doctor away. And there's truth in that, is that what we put in our bodies does matter. Making sure that we're eating whole foods and trying to cook as much as we can at home, if we have the time for it. And also exercise. Exercise doesn't mean you have to go and run a marathon. Like I say, it can just mean ditching the car for public transport. You simply walk more if you take the public transport. You walk more if you say, I'm not going to take the lift. I'm just going to walk the stairs. That can make a profound amount of difference to your health, and it doesn't really add any more time. I try to cycle to work and back as much as I can. So if you live close enough to do that, then you're not spending really much extra time out of your day if you can cycle to work and back. Because then if you cycle to work and back, maybe you don't need to, go out of your way to do exercise, and then you have more free time.
What I love about these conversations in this Well Doctor series is it's just the different perspectives that people come at the same things. And to your point about burnout and in and out of it, we've had a discussion on this series as well. The question has been raised: is it inevitable for passionate people within a challenging system? And potentially, and I'm an optimist, but I'm also, maybe it is. Maybe it is. So the key is identifying and course correcting. It's like meditation. It's not about being perfect and having no thoughts. It's about noticing when you do and coming back. So looking after yourself. It's a core foundation of the art of medicine, and it's a foundation that gets thrown out quite quickly in favor of all these other things. I think what I've loved about today's conversation is just how many areas there are to be a great doctor, to deliver great patient care, to be a great team member, to grow as a doctor, and to have an exciting, fulfilling career. There are all these great ways to do it, which are beyond what we learn in medical school. They're beyond the academics, but they are the thing that the patient will remember, that the charge nurse will remember about you. They're almost the impact and the legacy. These are the things that determine, to some extent, the impact and the legacy that we have as doctors. And I think this has been a really interesting conversation, drawing on your wisdom on areas that you've seen, that you've developed. And I think I read it somewhere, wisdom can't be taught, but it can be learned. And so everyone listening has to go on their own journey. But I would hope that this conversation has dropped some breadcrumbs, has dropped some opportunities to either be preemptive, as we talked about, and get ahead of things, or to notice when we're off track and to go, you know what, I remember that conversation with Nina, and had I done this could have been different. Well, that's great. Don't beat yourself up over it, but course correct and do it differently next time. And so I think this is the cool thing about conversations like this. Having a conversation about humility. It's a necessary conversation for doctors to have, and medical students, and for people like us, it is what it is. It's humility is an important part of being a good doctor. Managing our time, being preemptive, mastering this, and making sure we have a method, a fail-safe method, so that as junior doctors we don't drop the ball on the things we need to actually do. This growth as a doctor, I think it's coming in with that Zen mind, beginner's mind. It's coming in and showing initiative, being reflective, seeking that feedback, finding that balance between the confidence and the questioning to make sure that we can grow, and to being really cognizant of the words that we use. And finally, I love the fact that we, everything actually comes back, back to the foundation of looking after ourselves. Thanks for sharing the way that you've prioritized sleep, you've prioritized diet. The way I think it's, doctors, the interesting thing about these conversations is exercise has generally come down to how do you fit it in within a normal day, bike to work, use the stairs. There's some really great stuff there that I think is of such value. So thank you so much, Nina, for the conversation. I personally found it very interesting and useful. What final message would you like to leave people listening to, with, whether they're medical students, whether they're junior doctors, whether they're more senior doctors who have decided to go on a journey of growth? What would be your final message?
I think one of the other things I want to add to what we can do for ourselves and what we can do to make ourselves better doctors is reminding ourselves, like, why are we on this earth? What is life's purpose? And I've been thinking about this a lot more recently. And I think social connection, the treating each other like humans and, just going back to our core relationships, whether it's our friends, our families, our partners, and our colleagues, and our patients as well. Those social connections are so important. And I really worry about this current generation and our reliance on social media as a replacement for these social connections. There was a Harvard longitudinal study of adult development that showed that the number one thing that helped people with longevity and health in old age is the strength of their relationships. And when you have strong relationships, everything else just falls into place. Strong relationships, so you can talk about the problems that are going on at work, so that you can have people that you want to, do stuff with, that you want to meet up with, you want to share food, you want to go out for a walk together. These things fall into place when we prioritize our social health as well. So I think that's what I want people to be thinking about and talking about more.
It's a great message to leave people with when we consider the art of medicine is, if you're doing it well, you will build. It's a practice that builds relationships, that builds that team, that builds that social cohesion that's so necessary for the individual, but also for the care that we deliver our patients.